Welcome. Thank you for coming out this evening to the Wayland Library. We are excited to have Dr. Andrew Nierenberg here. He is the director of the Doughton Family Center for Bipolar Treatment Innovation at MGH and professor of psychiatry at Harvard Medical. He's also the co-director of Mass General's Center for Clinical Research Education and associate director of the Depression Clinical and Research Program. He also holds the Thomas P. Hackett, MD, Endowed Chair in Psychiatry at Mass General. Dr. Nierenberg graduated from the Albert Einstein College of Medicine at Yeshiva University. After completing his residency at NYU Bellevue, he studied clinical epidemiology at Yale. He then joined the faculty at Harvard Medical, first at McLean and then at Mass General. He focuses on clinical trials for bipolar disorder and depression with over 600 published papers and has been listed among the best doctors or the top doctors in America for the treatment of mood and anxiety disorders yearly since 1994. So we're excited to have him here. A couple housekeeping notes. We're recording, so this will be on Waycam and our YouTube page. You'll be able to rewatch and share. And if you're joining us on Zoom and you have a question, just put it in the chat. I'll raise my hand and read it aloud. Thank you.
Thank you. Thank you so much for being here. It's a nice intimate group, so please interrupt, ask me questions and other things. And I'm going to try to give you sort of an appropriate talk for a library, meaning that I'm going to show you a lot of books and make the story in a library about the books and the things that they say about depression, and try to give you a broad overview of some things. But again, if you have any questions, please ask. So it's everything you wanted to know. I'll try to give you some of that. We'll go over a little bit of some funny controversies that come out of books that were published, in the past 10 years, 15 years or so. And then I'll give you sort of facts that you might find interesting. All right, so let's start on our journey. The first thing is that this is dedicated to my former colleague, Andy Leon. And later in the talk, it'll be clear why it's dedicated to him. He was a brilliant statistician and methodologist down in New York, and we collaborated a lot. And sadly, he died prematurely from cancer and sorely missed. Just a great guy. So the first peculiar thing that I will tell you is that actually depression exists. And it's peculiar because there are books that basically say it doesn't. And there was this really interesting author who wrote this, and this guy actually pretended to be a patient, came to be in a study at Mass General, and basically lied, and then reported on that this was all kind of made up. I mean, this is you could probably take it out of the library. We have some stragglers. Hi guys. Hi Lane. Come on in. So it may seem a little odd, right, to say that have to assert that the syndrome of depression actually exists. And then there's more of a philosophical problem. And the philosophical problem is that it's language. And part of the problem with language is calling it depression, because this author basically said, look, it's almost as if you're not allowed to be sad. And that if someone's sad, well, you can just sort of medicate that away, which is really not what we're talking about. Although about 15 years ago in the depression group, we asked if people would give other people medication who were in mourning and were in pain because they were in mourning, they were anxious or not sleeping. And all of the younger doctors said they would, and all of the older doctors said they would not give them meds because there are things that are sad. And I don't know if anyone has experienced any sort of disappointment or loss in the past week. Perhaps it might be feeling something, of what's going on. But, look, it goes all the way back to Hippocrates. And part of it has to do with having a loss of some sort, right? Life is full of losses. And it's a problem if the reaction persists, right? If it persists too long, and I'll tell you the other things that are associated with that. But also, Robert Burton in the 1600s wrote this book of melancholy. And what's fascinating about Burton's book is that there's no mention of guilt, which is thought these days, in the modern days, to be a core cognitive symptom, a core feeling that somebody may have. But Burton didn't talk about this. And I have a colleague who's joined us from South Korea, and he said in South Korea, they don't talk about guilt. That's actually not a component. So there's a bit of context of where you are may define the symptoms that one has, because it's cultural. So again, there's stress that we all have, sometimes more, sometimes less. And for somebody who doesn't have depression, your mood can go down and then it pops up. And that if you do, it persists over time, right? It just doesn't let up, and it feels like you can't do anything about it. It's just kind of there. And how often does this happen? There were 2 large epidemiological studies done in the 90s and then the early 2000s, and it's pretty consistent. The lifetime risk of having a major depression is about 16 or 17% of the population. And in any given year, it's closer to about 6% will have it. So again, it's common, it's pervasive, causes all sorts of problems. And these are thought to be the 9 cardinal symptoms. And if you look at it and just scan it, right, it's sort of the way that it is formally defined is 5 out of the 9 symptoms, with the 2 cardinal symptoms that you have to have are either low mood or decreased interest, right? Those are the things that are cardinal, and then you have to have at least 5 out of the 9, and it persists for at least 2 weeks. But it turns out there are a lot of other symptoms that one could have, lots. And I'll just show you that. So again, you can scan it and you can read it faster than I can say it. But one is a whole set of psychological symptoms that people can have. And it can include things that you might not necessarily think is part of the depressive syndrome, including, a hypersensitivity to rejection, different than when you're not depressed, thoughts of actually aggression. People can get very irritable and have sort of, again, not characteristic type of thoughts. The other category are behavioral symptoms that one can have. And what may surprise you is workaholic, right? Feeling terrible, but feeling like you can bury yourself in work and somehow distract yourself from how you're feeling. And finally, the other category are somatic or physical symptoms that you could have. And people can gain weight, they can lose weight, but also have GI problems, heart palpitations, and other problems like that. So let me pause there for a moment and ask if you have any questions, comments, thoughts. Yes?
Why do you have some in red and some in black?
The ones in red are the cardinal ones. The ones in black are the ones that are not included in sort of the regular definition of depression. David?
Is there a signal noise issue? Because people, their personalities, their moods, they go up and down and they go up and down, and we call that the signal. How do you detect noise away from somebody who is, kind of up and down all the time?
Well, I think you have to get their story. Oh, so if somebody is going up and down as part of sort of a personality, I'll reframe it. How do you differentiate that from a syndrome of depression? So the way that you do that is that there's a cluster of things that go together in time. So it's not just mood. It's, again, sort of 5 out of the 9 is the formal. But when people feel it and have the syndrome, it's all together in a cluster that persists. And you can still have some people wax and wane, but it's not just mood. Does that make sense?
In terms of that consistent level of depression, are there ranges? Are there people who feel, just so low, so depressed that, it's sort of this clinical, and yet are there people who are sort of right at the surface of that, is it one or the other? Is there a range?
Yeah, so the range, there are several different flavors.
That you could still be diagnosed as
yes.
being clinically depressed.
Right, so you can have mild, moderate, or severe, right? You could have that. You can also have something called dysthymia. Dysthymia, you knew people in high school who only dressed in black and would listen to sad songs, that sort of thing, and read nihilistic poetry, but they were never positive, right? And that can persist for also a very long time. It's less clear what to do about that. But these are the people where, and I'll show you this a little bit later, and I'll show you some pictures of the brain, but it's where what's negative in the environment is what attracts their attention, right? And their thoughts, the valence of their thoughts are negative, more than positive. That makes sense? Yes, Elaine.
Everything that I've seen on the slides makes sense, except where in the world does burning or tingling come from?
People can feel sort of all sorts of somatic changes, and sometimes when people aren't really attuned to their emotions, they'll present with somatic complaints. And a lot of times they'll present to primary care with, I have these burning and tingling sensations, and they don't really realize that they have a syndrome of depression. The other thing is that it really is not a mood disorder, it's a total body disorder that people can have. And that's associated with inflammation and other total body changes.
Is there a different term for a situationally provoked depressive episode? If someone is having something go on in their life and they just feel blue for a while, versus someone whose set point is down here?
So the question is there a difference between somebody who's just sort of reacting to something bad versus somebody at a set point? Yeah, in the old days, we used to think that there was an endogenous depression that came from within and an exogenous depression from something bad happening. And we no longer think that because it's really, it's in many ways an exaggerated response to stress and loss. And again, you just you don't really bounce back from it. So something bad can happen, like maybe an election went the way you didn't want it to, and you might experience that as a terrible loss, and that can provoke somebody who's prone to depression to have an episode. That make sense? Peter.
And then the degree to which you're prone to it can change based on changes in your biology.
So the degree that you can be prone to it can be based on many things, not only biology, but also, there's an epidemic of loneliness that people have, and that social isolation can provoke it. You can have a genetic predisposition to it. You can also have a history of trauma that will also make you prone to have it more than not. Matt?
Depression at that level, is that something you just born with? That's the way you're wired? Or is it like one day something triggers in your biology, or triggers you in your life, or triggers your physiology that just flips a switch?
So the question is, are you just born with it, or is it something in your physiology where there's just sort of a switch, right?
It happens when you're 12, or whatever.
It's probably both, and there are probably multiple factors, and I'll show you that in a little while, all of the factors that can be associated with it that can converge so that somebody ends up having the syndrome. Yes?
Question from online. So many of the symptoms overlap with those of grief. How do you tell the difference?
Yeah, it's a controversy in the field, less so now than it was 10 years ago. But people can have both grief and depression. And the thing with grief is that there is a sort of characteristic aspects of grief that overlap with depression but are distinct. Because for most people, grief will follow some sort of a timeline. And there's something called complicated grief. And in complicated grief, you have grief overlapping with depression. I'm glad there are questions because that's what this is all about, right? Let me show you a couple of other things. You have to assert this too, that depression is actually serious, and I'll show you why. There's the fantastic memoir from William Styron, where he discusses his he discusses his depression really in very lyrical ways, and he says that depression is just a poor word for it because it's as if his whole being shuts down, it's a wonderful book if you ever read it. And then there's a more extensive book by Andrew. Talks about the Atlas of Depression and many different aspects of it. Let me skip that. And it has these multiple biological aspects. One of the weirdest things about being a psychiatrist, besides the fact people assume I'm kind of strange because I'm a psychiatrist, one of the strange things is trying to reconcile the biology of this 2-pound thing that's in our head with our experience every day, because we don't think about our brains. And our brains are unbelievably complex, and they're not fixed. They're changing as we are sitting here, right? Your brain is dynamic, it's changing, and not to freak you out, but you have cells wandering around in your brain that are testing whether synapses are working or not. And if the synapse is not working, it will eat the synapse. The microglia are crawling around in our heads, doing pruning all the time, right? And you're making and breaking connections multiple times every second, right? So you have this weird thing in your head, and yet, that's not our experience, right? Our experience is it's not even a river of thoughts. It's a network of thoughts. It's a network of feelings. It's adaptive. It's responsive. And, we sort of get through the day that way. And yet there are people who have written books critical of psychiatry saying that, they're trouble researching what's going on and trying to find the cause of serious mental illnesses. Well, that's because it's so complicated. It's much, much more complicated than a heart or a liver or a kidney. And so really what we're trying to do in the field is find the causes, understand the genetics, understand the biology, and then try to find better treatments as a result. So it's not so easy. And then there's this guy who I actually had a public debate with him, and he asserts that we psychiatrists are causing mental illness because we're treating it. And he does this backwards thing, blaming psychiatry. And he has a very influential, terrible website called Mad in America that just criticizes psychiatry and is anti-psychiatry. And he tries in this book, and he goes all over the world, he tries in the book to convince people to stop their meds. And yet, of course, he's not responsible for anything bad that happens to him. So these are the multiple biological aspects that are thought to be part of the whole syndrome. So one is called the hypothalamic pituitary axis. And it's one of the things that is associated with our stress response. Another thing has to do with the neurochemistry, and that's called the monoamine hypothesis. That just describes what class of neurotransmitters are, right? Because one of the ways that our neurons communicate with each other is that one neuron will communicate with another through an electrochemical signal. And again, that's complicated. And I'll tell you a little bit about that when I talk about meds. But that's thought to be dysregulated. It's not that you have something too low or something too high. It's that the whole system is dysregulated. Then there's an inflammatory hypothesis that whole body inflammation will cause depression. And one of the things that my group is really on the cusp of studying is the relationship between gum health and mental health. And it turns out your gum health is very important for your brain. It's an independent risk factor for Alzheimer's. It's also an independent risk factor for cardiovascular disease. And some of the treatments that are being developed are anti-inflammatory, which is interesting. The other thing is genetic and epigenetics, and it's very hard to figure that out because the syndrome is so heterogeneous, right? It's hard to figure out like which gene is doing what, and there's a lot of research on it. And again, I won't get into it, but there's one particular gene there, which is the GRIC5, and which has to do with a particular neurotransmitter called glutamate. And I'll talk about a little later, there's a treatment of repurposing an anesthetic called ketamine, which is also a drug of abuse. But that is thought to affect glutamate and decrease it, and it seems to work. There's also structural and functional brain remodeling sort of things, and then social and psychological things which have to do with really chronic stress. You may or may not have heard of the disorders that are related to really social factors, so that mostly in the red states, there are higher rates of suicide. There are higher rates of depression because communities have been decimated because there's no work, right? And families have been decimated. So that's the social pressure and the social stresses that people can have. Lenny.
You say a little bit more about the HPA axis dysfunction hypothesis.
Yeah, so the hypothalamic pituitary adrenal axis, right? It is essentially a pathway that also will react to stress, right? So the hypothalamus is an area in your brain. The pituitary is part of your brain, but it also is an endocrine organ. And the adrenal glands will secrete cortisol, which is a stress response. And so that whole axis can get dysregulated in depression. Does that make sense? Okay. Yes.
Were or are there any drugs which can cause depression? For example, Ritalin.
Ritalin is a stimulant and it doesn't cause depression. There are other medications that can cause depression that are used for medical problems, but Ritalin is not one of them. That actually shows the HPA axis, and again, I'm not going to get into the details of that. But again, it's that in people who are depressed, you can actually have an increase in the adrenal gland that will then hypersecrete cortisol, which is a stress response, and then cortisol then will have effects on the brain. Make sense? We're good?
But Andy, on that, are you suggesting that the dysfunction of this system and extra secretion, I don't know if you were, what's it caused by?
Nobody really knows. Nobody knows the causes of it.
The cause can make you different. But the reaction here, the system malfunctioning like that.
So the system can malfunction and then it goes into overdrive. The cause of that overdrive is not known, right? We just don't know that. The other thing, again, because I'm trying to show as many books as possible in the library, this guy, Olaf Sporns, really published this gorgeous book on networks on the brain, and then a subsequent book on discovering the connectome. The reason I'm telling you this is that our brains are like a big party. And our brains are like a big party because at a party, you'll have people who will gather, they'll cluster together, they'll communicate, and then they'll go and talk to other people, and then they'll cluster and they'll communicate, right? And you have people, kind of wandering around and interacting. And our brains are made up of these dynamic networks that will form when you're doing something, mostly collapse, and then do something else when you're doing something else. And there are characteristic networks that are associated with, if you're trying to see what's in the environment that's important, if you're trying to see what should your attention be paid to. There's even a network that will form when you're just doing nothing. And that's called the default mode network, right? That's what it's called. And what happens is that it looks like in a lot of the serious mental illnesses, these networks are dysregulated. Either you get stuck in one, or you're flitting too much back and forth between them. So in the brain networks now, right, and particularly I want you to look at the third one, which is negative bias. Oh, you can see that on this there. The negative bias one. And these areas in the brain start to go in sync. That's actually how we know this, because you can use something called functional MRI, and you can see the areas that are actually in sync, right? They're all firing kind of in the same way. And what happens is the negative bias network is really enhanced in people who are depressed, which makes sense, right? But it's starting to show a brain part of this. Now, part of what's really fascinating about this is that there's now a technology to target these areas with a magnet. And it's called repetitive transcranial magnetic stimulation. And there's now a technology where they'll do a brain scan, try to see where they need to have that magnet do what it needs to do, and then they'll apply the magnetic field to that, and the magnetic field turns on and off. And it works. It's really quite remarkable. But it's moving towards what's called precision psychiatry. So it's not just, you just do it. It's like, okay, in this person, here's this part of the brain that makes sense to stimulate.
Is that like a magnet, almost like turning on and off a switch sort of thing, or like
the question is the magnet like turning on and off a switch? Remember from high school biology, if you have an alternating magnet, you'll cause a current. That's essentially what it does. And if you do it at a high frequency, like 20 hertz, it'll stimulate the neurons. And if you do it at a low frequency at 10 hertz, it'll actually shut them off. Yes? Yes. So we have a group that does photobiomodulation. And in photobiomodulation, you can use near-infrared light that will pass unimpeded through the skull and will actually affect brain energy metabolism. And there's preliminary data that it may work for depression and other things. Yeah. So it's and there are these little devices that you can start to even buy that have near-infrared light that may help with all sorts of things. But it's an active area of research.
Are these regular procedures you're talking about, or is
So repetitive transcranial magnetic stimulation is approved by the FDA. Yes.
I understand that there's a more in-depth magnetic therapy, one that uses a computer while they're doing the stimulation, and one where it's more of a guesswork sort of crown that they put on you. Are you familiar? Do you know what I'm referring to?
This is the magnetic one, or
Yes.
so there's deep RTMS, and it uses a different coil so that the signal goes deeper than the regular one. The regular one will go about 2 centimeters in or so, and the deep TMS can reach different structures. There's and again, you can use neuroimaging to try to see where you need to do that. And there's a protocol now called the SAINT protocol.
Okay. And there's one that isn't the SAINT protocol. And do you think that the one that isn't the SAINT protocol is as effective or does work compared to the SAINT protocol?
So the question is, does regular repetitive transcranial magnetic stimulation work as well as the SAINT protocol? The difference between the regular one is it takes 5 days a week and 6 weeks to get somebody to respond. The SAINT protocol, it's much more intensive, and you can give repeated trains of stimulation in 1 day, and you can get somebody better within 5 days. But the SAINT protocol combines the intensive treatment with the neuroimaging to target certain areas. And the SAINT protocol, I think it might be approved by the FDA now.
And do they know how long that lasts when you?
Yeah, it has to be done again. I mean, it's not you just do it and then it's fixed. So it can last maybe up to a week or so, is my understanding, maybe a little longer. It's not that difficult. Actually, one of the weirdest things about the repetitive transcranial magnetic stimulation, it's loud because the turning on and off, it makes a lot of noise. So you have to give people earplugs and things like that. But the only real side effect, by the way, of the magnetic thing is people get a headache because the magnetic stimulation will also stimulate the muscles in your scalp. So you'll have repeated scalp movements, right? All right, so this is the other thing I have to assert. Why would I have to say that antidepressants work? There are literally thousands of clinical trials. And that's because there was actually a big controversy about whether they actually work or they don't work, and what do they really do, or what do they really not do, or what does placebo do, or what proportion of response is really placebo response and not the antidepressant response. And then there's this famous book where Peter Kramer, who's a very reasonable psychiatrist and thoughtful guy down in Rhode Island, wrote this book because he was saying, I had this weird experience where I'm treating people and they said they're better than they ever were before. And it kind of seems cosmetic to me. And he used the term cosmetic psychopharmacology and somehow, as if it's not so serious. And I'll show you what he wrote later on to counter what he wrote. He changed his mind. But this guy is actually at Harvard. He moved from one place, went to Harvard, and he's made his whole career that the antidepressants don't work, right? And he sort of reanalyzed the data in a rather peculiar and idiosyncratic way, but it seemed compelling. So a lot of people actually believed him, bought his book, and think that it doesn't work. Then there's the conspiracy theories of how the psychiatrists are working with the pharmaceutical industry just to numb people and to make money. Then you have this guy who worked at the Harvard Student Health Service as a clinician and then said he was a Harvard psychiatrist and that he didn't think that the antidepressants worked at all and it was making people really terrible, right? That was his whole credentials. Then there's this guy who's also an anti-psychiatry psychiatrist in England, who's against everything, and thinks again it's all a big conspiracy. And then Peter Kramer came back and wrote this book called Ordinarily Well: The Case for Antidepressants. So he changed his mind about that. So again, you can take all these books out of the library and get a really interesting view of things. All right, so these are the antidepressants, right? These are the ones that work now. Several of them have a common mechanism of action, and you may or may not have heard of the term SSRIs, which is specific serotonin reuptake inhibitors. So that would be the citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. And mostly what that does is one neuron will release the neurotransmitter serotonin. It will hit the next neuron and hit a receptor. Then there's all sorts of interesting things that happen once it does that. And then it goes back into the neuron that it came from. And what the SSRIs do is they block it from going back in, and then they hang around more and they hit the receptor again. But it actually doesn't increase serotonin. It does wacky things because it increases the concentration. And by increasing the concentration, it keeps on hitting the receptor back here that's blocked. And then the receptors shift and change and then cause all sorts of other changes downstream. It's very complicated. Some of the other drugs work in other ways. The one that I'll tell you most about here is bupropion or Wellbutrin. It doesn't touch serotonin, has nothing to do with it. It affects norepinephrine and dopamine. And then I told you earlier about S-ketamine and ketamine, thought to work through something called glutamate. And then there were the real old drugs that I won't mention. So there is a guideline for doctors and for patients called CANMAT, or the Canadian, I'll show you it later, but it's the Canadian guidelines that are probably one of the best in the world. And they have first line, it's kind of like Consumer Reports, right? With the little circles of what there's good evidence for. And they have first line and second line and third line in there. And again, if anybody's interested, I could send you what those papers are. And then similarly, they have what the side effects are, because they all have side effects of some sort or another. And then the balance is to balance how much it helps versus what's in the side effects. And then, of course, we recently voted on this. And as a state, we said, nah, not really. Maybe we shouldn't make it, widely available because the evidence is limited. It's promising. It's interesting. It may actually help people with PTSD in particular, with treatment-resistant depression. My colleagues across the world who study this are very enthusiastic about it. But there was a clinical trial and a company that just got rejected by the FDA a few months ago because they did the trial wrong. But it's coming down the pike. I mean, this is really in the future and be very interesting.
The
Yeah.
mechanism, if it's known, I don't know if it's known, by which these work versus the whole list of antidepressants, which had multiple ways of working. Is it understood?
Yeah. So it is totally different, but there's kind of a common final pathway. And the final common pathway is that it promotes the growth of neurons and promotes the growth of connections between neurons. So I told you like one neuron is like this and like that, except it's much more complicated than that, where a neuron will have like a bunch of things along its axis that an axon, and there are little boutons there. What this does, it makes that grow much faster. And it's thought there's some relationship between neurogenesis and also synaptogenesis and response, although we don't quite understand it, right? But this does it much faster. Ketamine also does it faster, right? And you can see that in all these interesting animal models and other things like that. That makes sense to everybody? We're good? Okay. this is actually one of the studies from my colleague Andy Leon that this is dedicated to. And again, it was trying to counter at the time the narrative that the antidepressants don't work. And what Andy showed in his analysis, that the odds of response increased with high intensity treatment. That's all this really says. And then there's a whole bunch of other things, and I'm not going to show you the data. That some people are saying, look, you don't really need antidepressants. All you need to do is exercise, right? And my buddies from the bike group are here, and exercise helps a lot, and exercise also promotes neurogenesis and synaptogenesis. And it might be for people really mildly depressed, exercise may be good enough. It may actually work, and there's some data for that. But, if you compare a lot of things to the antidepressants, what can work for mild depression are these evidence-based psychotherapies, particularly cognitive behavioral therapy, can work quite well. And it helps somebody think about how they're thinking rather than just being in the stream of thinking. And it gives them an alternative explanation for what's going on in the world. So when people get depressed, their thinking becomes very rigid and very stereotypical, right? So they'll think that they're responsible for everything, that they can't make any mistake, that if they make a mistake, it shows how terrible they are, right? And it doesn't have flexibility. Cognitive behavioral therapy allows people to get out of that rigidity. And again, it can work quite well. The other therapy is a blend of mindfulness and cognitive behavioral therapy that comes from these guys from Canada. And I know Zindel Siegel, and John Kabat-Zinn, of course, was a famous meditating guy. And so they call it mindfulness-based cognitive therapy. And that also not only works well acutely, it also can prevent the depression from coming back. And depression does come back, but the antidepressants can lower that probability substantially. So in a classic study, it showed the recurrence rate over 15 years for people who recover from an episode of depression. If they're not treated, 15 years later, they have a 90% chance at some point to have at least one more depression, if not more than that. And the antidepressants reduce that probability substantially.
Are you saying that stay on the antidepressant that whole time?
So the question is, do you have to stay on the antidepressants that whole time? Yes. But about 50% of people who have one depression will eventually have another, which means 50% won't. And the general data suggests if you have one episode of depression, you should stay on the antidepressants for at least a year, and then you can come off of it and see what happens. But if you have recurrent depressions, if you've had at least 3 episodes, you're probably going to have another one. And that in order to prevent that other one, you need also to stay on the antidepressant. Lenny?
Does that also apply to people over age 50 develop depression?
So the question is, does it also apply to people over 50? And because Lenny knows his stuff, yes, it does. So if you've had your first depression over the age of 50, it's likely to come back. So it's one of the factors to say, look, you're doing fine. If you come off of it, you're going to risk having another depression. But again, it's a whole balance of side effects and efficacy and risk.
Is it different in young children, let's say under 12?
So is it different in children under 12? So children under 12 can get depressed. And here it's much more controversial about the efficacy of the antidepressants. And it looks like some of them were able to separate from placebo and others were not. So it's really controversial about it. And there's also the worry that the antidepressants themselves in kids can provoke them to have suicidal thoughts. And there's a whole controversy about the relationship between antidepressants and suicide, which I will tell you about in a moment.
I have to something like ADD, depression and ADD. And then I'm also interested in terms of an alternative, there to psilocybin cold plunging, you mentioned exercise, and had the other one on this my time.
Heat.
Yeah.
So the question is, what about alternative treatments like cold plunging, exercise, heat? There's a whole interesting area now, and my colleagues have done studies on this, that hot yoga can treat depression. And there you're combining exercise and heat. The cold part, I think there's less data on that. But at least heat turns out to be, it's good to have a sauna. It's good for you. Yes, that's right. That's right.
And then what about ADD?
Oh, so the thing with ADD is that kids and people with ADD are at a higher risk of having depression as compared to those who don't have ADD. People who have depression are at higher risk of having ADD than people who don't. So again, it's another sort of dysregulation of attention. And the whole thing about ADHD, attention deficit disorder, it's not a deficit, it's a dysregulation. That's why you can have kids with ADD hyper-focus on a game that they like, right? Played for 6 hours. It's not a deficit, it's a dysregulation.
And how does anxiety fit in there?
So about 60% of people with depression will have anxiety, and people with anxiety will also be more prone to have depression. And again, it's not like you have two different things. It's different ways that your emotional brain world can be dysregulated. So a lot of people who are taking antidepressants will also take an anti-anxiety drug. And some of the antidepressants have an FDA approval for anxiety.
But isn't it also true that there's some medications that could be given for depression that will actually increase anxiety?
So the question is, can some of the antidepressants increase anxiety initially? Right. So this is the thing with the kids. The kids can have an uptick in agitation and anxiety, and the savvy clinicians will treat that with an anti-anxiety drug initially. And after they're used to the antidepressant, they don't need it anymore. So it can be an initial reaction to having an antidepressant in their system. Make sense? All right. All right. So this also, this is good. I'm going to tell you a story, and you're going to be very surprised. But this has to do with my colleague, Andy Leon. And believe it or not, you can find this. In 2010, the House held hearings where my colleague Andy Leon went because they were thinking of banning antidepressants in the military because somebody wrote a book basically saying the antidepressants cause suicide. And it was a misinterpretation of some data, and it had to do somewhat with treating kids, and kids had an increase in suicidal thoughts. But you're talking about 2% versus 4% of a total group of about 4,000 where nobody actually hurt themselves at all. But it led to hearings also at the FDA that led to a black box warning on the package for these things that it could provoke suicide. And there was a whole thing that actually came out of McLean Hospital, and there were these cases that happened that turned out not really to be true. But some people can get very agitated, right? And have an increase in their anxiety, and they can have an increase in suicidal thoughts, but it's rare, right? And I can tell you, I've seen it maybe once or twice where somebody's felt a lot worse on an antidepressant. Anyway, they held these hearings, and there was a Democrat who was running this, Bob Filner, and my colleague Andy, statistician, methodologist, designer of clinical trials, very experienced, was telling him, look, here is the data. And this is what the data show. And this is what Bob Filner said. Literally, this is in the transcript. Right? It used to be you could watch a video of it, but it's not available anymore. You know, and it would say, it's like, are you kidding? Right? So Andy, he was the sweetest guy you would ever meet, generous, calm. He got so pissed off at the guy who wrote the book and was next to him. You know, he said, "You, sir, are not an empirical scientist," and that's what made Bob Filner, make that comment. So this is this other crazy guy who's another anti-psychiatry psychiatrist, and basically saying that the drugs cause violence, suicide, and crime. Right, and he testifies at all of these trials and these other things. And I've never seen Andy angry, but he was really angry at this guy Bregan. But it turns out Andy also did a very careful analysis, and that it in fact decreases suicidal behavior in a very long longitudinal study that he was involved in. And then one of his colleagues also showed in a very sophisticated statistical analysis how it decreases suicidal thoughts. The last two things I'll talk about are, I've told you about TMS. There's also electroconvulsive therapy, which is still around. There are more people who get ECT than have their appendix taken out. Right? Our ECT service is always full. And it works, and it works frequently when other things don't work. And in the sophisticated ways they do it these days, there's a minimal effect on memory. That's what people are worried about. But people think about One Flew Over the Cuckoo's Nest all the time, right? And that's just not the way it works. But there's still plenty of people. And then finally, I just want to mention bipolar depression, because it turns out for people who have manic depressive illness, bipolar disorder, the percentage of the time that they're ill, that they're depressed, is 75%. So bipolar disorder is mostly depression, and less so with mania, hypomania, and that sort of thing. And while I won't go into the treatments for that, there are some specific treatments for that are different than the antidepressants. This is also another great book if you've never read it. It's one of my colleague, Kay Redfield Jameson, who's a very well-known psychologist at Hopkins who has bipolar disorder. And years ago, she came out with this book that described her own experience of being treated and what it's like. And she's written some other books on creativity. Is really extraordinarily thoughtful, just this wonderful, wonderful person. And she would have terrible suicidal depressions, really bad. And then there's a newer colleague of mine, Sarah Schley, and we're collaborating on some things. And she recently wrote this book and has a website and is trying to help people who have more of a hidden form of bipolar disorder. So she had 25 years of very difficult to treat depression until somebody finally made the diagnosis. She was bipolar. She had bipolar disorder, was treated, and really is much, much better. And I'm going to leave you with a couple of resources. One is, this is from CanMat, and it's a patient and family guide for treatment that's available from CanMat that's really quite good. I'll let people take pictures of that. And then there's also this wonderful organization, DBSA, that has local chapters, national chapters. They do a lot of education. They have peer support, and extraordinarily helpful. So that's the summary of everything, and happy to take any other questions that you have. David.
So mostly we've talked about interventional psychopharmacology and other approaches. How do you view psychotherapy in conjunction with these other things?
So that goes back to cognitive behavioral therapy, mindfulness-based cognitive therapy. There's another therapy I didn't talk about called interpersonal therapy that can also help. When people are severely depressed, they can't do the therapy. They sort of can't even use it. When they're less depressed, then they can use it and you can combine it. I firmly believe from the data that the combination really helps people get well and stay well when they can do it.
I remember on PBS there used to be this guy, when they were doing fundraising, they would repeatedly have this lecture. He had a book called Healing the Shame That Binds You. Probably some of the people in this room are old enough to remember that. It's probably 40 years ago. And it reflects a certain worldview that you can solve these problems with enough, you say, reflection on how your mind works. I think psychopharmacology has come sort of mostly since then. So I wonder how things have changed.
So the comment for people online is that years ago there was a thing on PBS and there was a claim that you can do it yourself in a sense on your mind. Look, I've treated people who've really struggled with depression. They would tell you you're out of your mind. There's no way they could do that. And in fact, people will tell me it feels like their brain shuts down, like they can't think, and they just can't do anything, which is very distressing to them when they're like that. So it's not like you say, oh, I'm going to think my way out of it, and then it's all going to be great. When it's severe, it's severe. When it's mild, again, then the cognitive therapy can work, and people can restructure their thoughts in many ways, and ways that are adaptive and quite helpful. Yes?
In the chart that had antidepressants in 2 columns, I get the impression that the left column and the right column are different methods.
No,
Can you switch from one to the other without a lot of anxiety or problems?
Yeah, they work slightly differently, right? They hit slightly different receptors or groups of receptors.
I guess like if you're in column A, you switch to column B.
No, it's not like that. It's not organized that way. And it's more of an art than science to figure out if this thing doesn't work, what do you do next? Yes.
It seems to me that if they're effective, that list should be 2.
Well,
why, as a psychiatrist, and I come in with a problem, why do you pick the 3rd one down versus the 6th one down or the one on the right?
So what I do is I give people a menu of reasonable choices with no more than 3 choices.
Are they working differently?
Somewhat. They're not exactly the same. Even the ones that are in the same class, they all work a little differently. It's like antihypertensives. It's like anything else, right? Not everything works 100% in 100% of the people. So you have to have options for people to figure it out. Also, some of the newer ones have less side effects or different side effects than some of the older ones. And again, they're trying to get closer and closer to the physiology and target the physiology as best as you can. Yes?
I'm wondering how somebody with severe depression would have the mental capacity to figure out their choices, the choice you'll give.
Well, there are some people who will say, look, just tell me what to do. Yeah. Right? And there are other people who say, I want to think about it. There's another book called The Practice of Autonomy by a guy named Carl Schneider. And he talks about any clinical decision will be on the spectrum of physician authority versus patient autonomy, right? And if somebody says, I can't choose, tell me what to do, you say, fine, take this, try this. But most of the time, it's collaborative, right? Most of the time, it's like, well, how can we work together for the common goal that you can feel better? The days where I can give a physician's order, that's gone, right? That's like good. That's good that it's gone. I mean, I've been doing this for 40 years. And way back when, you just told somebody what to do. And then you realize, we don't like to be treated like that, right? When we're all patients. We all have the role of patients. And we want to be able to have shared decision making. And I think that works best. Yes?
A few questions online. 2 of them are kind of related. One is, have humans always had depression? But someone else asked, not not meaning to be facile, but given the state of the environment, politics, etc., might depression and anxiety be an appropriate response? Is the criterion of what constitutes a problem whether one or one can or cannot function?
Yeah. So as long as people have been around, people have gotten depressed. And there's another theory to try to explain, well, why is that so? What's adaptive about that? And it may be that withdrawal from the world may be appropriate sometimes, right? And that's how you survive. You're not going to be the person who goes to war. You're going to stay home, right? That's one thing. The second question is, look, we think we might live in more stressful times than anybody else before. Life has always been stressful, right? And life has always been challenging. We all live with losses, right? One of the great challenges of being human is being attached to somebody and knowing at some point it's going to end. Either you're going to end or the other person's going to end. It's very challenging. But that's why we mourn and we go through all of that. But that's just one of many, many facets of our lives, right? It's just the way we are. Elaine?
There was a time when somebody would go on antidepressants and come back to the doctor 4 weeks, 6 weeks later and say it didn't work, and would hear, well, just try a little longer and maybe it'll work. Has that changed?
Yeah. So the comment is that at some time, if somebody wasn't better after 6 weeks of treatment, you say, well, just stay on it for longer. Well, there are two aspects of that. One is the duration of treatment, and will it actually help somebody get better? And the other is just time, because a lot of the depressive episodes will be time limited. For a lot of people, it'll fade over time. But now we have ways of calculating the probability of response at any given time point, given non-response earlier, right? So if somebody's not doing well at 6 weeks, they're probably not going to do that well at 8 weeks, right? And if they're not doing that well at 8 weeks, they're not going to do that well at 12 weeks. So it becomes a dynamic back and forth decision. Does that make sense, Elaine? Yeah. Yes.
Works on serotonin or dopamine or other transmitters. Is there any testing or things we could test to say this is a serotonin driven?
Yeah, no, yeah. So really, in some ways, the question is, can you figure out the biology and then match a treatment to that biology? Well, like we hope they do with cancer. It turns out cancer is much more complicated. Even if they find the right target, maybe you can buy a couple of more months. It's not like for a lot of people, you don't cure it. There's intensive research to try to understand the biological subtypes and then to match the treatments with those biological subtypes. There's somebody at Stanford who's named Leanne Williams, and she's doing a clinical trial based on that, to show if you have this particular subtype, you'll respond better to A versus B. And if you have this particular subtype, you'll respond better to B than to A, right? But it's very intensive, difficult work. Yes? What percentage of patients need to be on more than one drug for depression? Probably around 30%. Right, and there are medications that are approved to augment the antidepressants. For example, there's one repurposed antipsychotic called Abilify or aripiprazole, and that's approved to add to an antidepressant when it's not working.
Do some of them sort of stop working, just the body get acclimated and you need to try something new?
So the question is, does it stop working? So there are two terms for it stop working. One is called tachyphylaxis, and the other term is poop out. and you can have somebody who's been doing well for a while, and then even while taking the antidepressant, they can get depressed again, and it's not clear what to do at that particular point.
Just coming back to alternatives.
Alternatives. You want to know about alternatives?
I do. One that I read about, I may be incorrect in what I'm saying, but it's like disruptive therapy, where I was reading about people who fall into some type of depression, and the idea is to break the like brain cycle somehow and disrupt that, the brain pathways there. And the other is sunlight, vitamin D. I swear, it's like you go to Cayman Islands, everybody seems to be happy.
So one thing is you mentioned disruptive therapy. I don't know anything about it, so I can't comment on that. Vitamin D is actually really interesting, and particularly one form of vitamin D called a cholecalciferol. And if you take enough of it, it may actually have an antidepressant effect. I'm working with a group and we're looking at how we can repurpose that for people who have bipolar depression.
Can you get that from sunlight?
I think, sunlight, sand, the water, a sailboat, the love boat, right? That you could.
How much cholecalciferol is enough?
Well, if you look, there's about 50 milligrams in 2,000 international units of D3. It's unclear, but maybe 100. But again, it's not clear. But there's a lot of interesting research being done on vitamin D. Yeah, that's D3. If you look at vitamin D, and it'll say vitamin D3. There are two forms of it, but you want the cholecalciferol.
Is that also true of omega-3s? Isn't there some talk about omega-3s, high doses of that also being effective?
That's a long story, and it's very complicated. But there's some evidence that eicosapentaenoic acid may be helpful as opposed to the other form of omega-3, which is docosahexaenoic acid. There are a bunch of studies that are kind of mixed. If you look at it, you'll see if you buy omega-3, there's EPA and DHA. All right, EPA is eicosapentaenoic acid, DHA is docosahexaenoic acid. And there's mixed studies on it. I mean, it actually sort of started in 1999 at McLean by a guy named Andy Stoll. Subsequent to that, there were 5 studies, and the other 4 were not positive. And then there's some recent studies that were done by a guy named David Michelon at Mass General, and it was sort of positive in some people, right? So it's not entirely clear, but you may need actually very high doses of EPA, and that might be helpful. And that has anti-inflammatory effects. It has effects on brain chemistry and some other things. That's do no harm. That's perfectly reasonable. Yes.
Someone's asking what you think of the newest meds seen on TV for depression, and are they better?
I don't know. The question is, are the antidepressants that are shown on TV are they better? I don't watch TV, so I don't know. I wouldn't know. Vitamin C, there's no evidence. The vitamin B12 would be for people who have a deficiency. If you don't have a deficiency, I don't think vitamin B12 has an effect from anything that I know. Yes? So some people will have low vitamin D that is actually causing their depression. And that giving them the supplementation, so measuring it makes a difference, and giving them enough can make it so that they're not depressed. But if people who are depression have low vitamin D, I don't know. I don't know what the rates are. Okay. Oh, he's keeping you.
We seem to be talking about episodes of depression. Are they certain grades of depression from mania scale?
Yeah, there are ways to measure it. And the most severe form of depression will be associated with delusions or hallucinations. And that's called psychotic depression. That's really severe, right? And many times it will require, emergency intervention. Well, thank you so much for coming out.
I think so.